I may not be around, but you will. Now, in the United States, we have a two-tier system of medical care. In the past, it was very good. The top tier, fee-for-service, we went into that. We had Medicare, government insurance for those over 65 or severely disabled, and patients could choose where they want. They could go to whatever hospital they want. They just had to pay some deductibles, some co-pays, and we only needed to have an authorization from an insurance company for surgery. Okay, in other words, the high-cost items, we needed approval. But not for Medicare, we did not need approval. The lower tier, they were taken care of, economically disadvantaged. We have public hospitals, we have clinics. They paid a certain amount, the low amount for you to go to a private office. This was a training ground for our interns, residents, and fellows. And the insurance company authorizations were just needed for surgery. Very simple. Very little paperwork. There was no big deal. At present, it's hell. The top tier is shrinking. They're being caught up in what we call health maintenance organizations, two systems, capitation, where the doctor gets a set fee, or his enrollment, whether he sees them or not, set fee per patient per month. So the more patients you see, the more it costs you. The fewer patients you see, the better off you are for profit. Then there's the other fee-for-service, still through the HMOs, but they regulate. You'll see that the pressure is on you to join them, and it's a source of new patients. But every patient has to be authorized to see you for each and every visit, and if frequent visits are necessary, we have to get an authorization for each one, plus procedures. So, even the top tier patients, they're being sucked up by the HMOs because they're told that there's no annual fee, no deductibles, no co-payments. They'll even send these 90-year-olds to a gymnasium. They're told some restrictions may apply, but they're not told what the restrictions are. Well, you're going to see them in a minute. The lower tier people, even those on Medicare, they're being forced into the HMOs. Lower fees than Medicare. It includes Obamacare. Patients get insurance, but not the medical care, because it's a disincentive for doctors to care for them. They're getting paid so low. Not good. So with the HMOs, whether it's the top tier that join them, the bottom tier, authorization, authorization, authorization. You need an authorization if you're going to die. You cannot die unless you're authorized. Who does the authorizations? The IPA committees of primary care physicians or the insurance company HMO. The desk clerk, what I call high school dropouts. The decision makers have a vested interest in not authorizing referrals and treatment. It costs them money. Or here, great news. The shareholders have approved your heart bypass because they're owned by shareholders. So patients are seen as unprofitable. So here, a wife, another. Your respective physician with lucrative HMO contracts. How could you go broke? I started treating my patients. Now, under capitation, as I mentioned, the way a physician makes the most money is not by treating patients at all. This is the money slide you asked about. Yeah, upper tier service.
Is this everything?
Yes, it is. And the lower tier service.
No.
Don't laugh, it's true. The London Bobby, she still tells me where to go. And sometimes it's not so nice. So you get an idea. So here, I have to show this. Bedside manners. Chris Christie, the governor of New Jersey, when Ebola came to the United States. And this is the nurse that came from Africa. She was fine. but they all jumped on her. With Christie and other medical unprofessionals, turn your head and shut up. You're contagious. Shut up and get in the tent, dummy. But she's not even symptomatic. She wanted to go and ride bikes and be in public. I want a second opinion. He calls in the governor of New York, Cuomo. I recommend to do whatever the latest polls say. I had to show this. All right, now why has the United States been a leader in innovation and advances in medical and technology, no matter what? Why do they come from other countries for their training? No, we're not smarter, we're not prettier than you, but this is good. I'm going into this. We have a good symbiosis between academia, government, and private industry for the funding and exchange of ideas. And a lot of this is accelerated by war, unfortunately. Alan Turing, the British code breaker, he had the concept of what we now call computers, rockets, jet engines, everything, nuclear power, medicine, penicillin, prosthetic limb improvements, and women incorporated into the workforce, what we call them Rosie the Riveter. Out of the kitchen and into the factory, try to put them back into the kitchen now. No way. Now, today, can we maintain the lead in the United States? We have a lot of constraints. Costs a lot of money for drugs and equipment to go through the FDA, and they're overly concerned about misusage. Look at this. You used the eczema laser before we did. We made it, you used it. Medications, combo drugs. We can't put Timolol with Latanoprost. You can. IOLs, new styles. You're using it very effectively. We can't use it because it costs a fortune. It's going through the FDA. Medical liability constraints. God forbid that anything happens. Gee, lawyers, they smell money for any adverse income, and there's an 800 number, 1-800-BAD-DRUG. The lawyers are there to help you. So, can managed care be good for India? Let's look at India. Middle-class workers, lower-class workers, who's going to be covered? Who's going to pay for it? Government, employer? Who? Aging population with increased technology, less... who will monitor it? The government? Who's going to be honest? Let's talk about the future now, and I'll sum it up with this. Because we are going into artificial intelligence. Are we going to be supplemented by computers with artificial intelligence? Well, with all the information now, there's so much coming in that computers will compile the information. Hopefully they'll put in the patient data and work with the doctor. Will they be able to recommend, perhaps even prescribe treatment course? Remember, we have the license, the computer doesn't. In surgery, will computerized machines supplement the surgeon and be run by providers? I'm not saying doctors, providers, because they're so technical. LASIK is one. Femtosecond cataract surgery, we're just at the beginning of it. And for other fields, the Da Vinci robotic surgery, where do doctors fit in? We have technicians running that. And here's Turing, Alan Turing. Why humans shouldn't need the fear of machines all around us? Well, we should have a good symbiosis. Well, IBM's Watson machine, it went to medical school for 3 months in the Cleveland Clinic, Learning College of Medicine. And it was there to help doctors, help physicians cope better with the huge amount of new research and information. Because look at this, the half-life of existing knowledge for us in medicine is about 4 to 8 years after you graduate medical school. After that, it's pretty much obsolete. I'm doing nothing that I learned in medical school. I'm doing nothing that I learned in residency. It all came later. So what we learned in medical school loses its accuracy, and it's accelerating. Let's go into a research example, the gene P53, a crucial protein called the guardian of the genome. And more than 70,000 papers have been published on this alone. Watson read them all. And if we were going to do it, it would take years. We could read maybe 5 research papers a day. It would take 37 years to digest it. 38 years. So, then we have the hastening pace of discovery to open up new doors to new therapies. We have a 69-year-old woman with vital signs. Could we put this in the computer to collect and assess all the information? Computers should work with us in a symbiotic relationship, not replace us. They should augment and enhance our work, and that's what the future should be. R2D2.
Thank you very much, Dr. Schultz.